I'll request Dr. Naresh to give his presentation on newer bugs, newer drugs, and new technologies in the management of post-operative endophthalmitis.
Thank you, madam. Thanks for the invitation. And just a disclaimer, actually. See, most of the organisms which we'll be presenting are from our library. But during my microbiology, I have not gone through these organisms. So I will not be spelling or pronouncing them properly. So just don't make fun of me when I am pronouncing wrongly. Okay? So if you can pronounce correctly, you can tell me. So a lot of things has been discussed about endophthalmitis and its epidemiology. Just to brush up, it's basically because of the colonization of the organisms in the vitreous cavity. And we have a lot of classification. And sometimes we may get a case of endophthalmitis without pain. That is in almost 25% of the cases. Still we have to suspect. And there need not be any hypopaean in 15% of the cases. Still you have to suspect endophthalmitis, especially in case of fungal, we rarely see endophthalmitis. These are the usual organisms. This is how we used to deal with. But we'll be discussing more of unusual organisms which we have come across during our practice. It can be both gram positive or gram negative. And if the virulence is slow, especially in case of cluster, it's a disaster because it grows slowly, difficult to identify. Then the long course and the antibiotic resistance all lead to a negative outcome in these cases. Then some of the highlighted organisms are the one which we have come across in our practice as a rare bugs. And some are clusters, of course it might overlap, but I will not be going in detail. So identifying is not that difficult, especially in case of cluster. If the organism is rare, it is easy to identify. If the organism is common, it's very difficult to identify. So one first thing is this Chytococcus sedentarius. The patient came, and the patient, the organisms were resistant to almost all the drugs. So he came on 18th post-op day with light perception, all the features of endophthalmitis. This is how we started. And all cases we admit on day 0, we go for intravitreal antibiotics because if the patient comes late, we don't want to have any delay in that. And if needed, next day, the core vitrectomy is done. So the patient underwent core vitrectomy with the intravitreal voriconazole, Vanco and Cefta. And patient was doing fine. But again, after a few days, he came with, again, drop in the vision with PL. This time we have done the re-core vitrectomy. So the main idea is whenever there is a re-core vitrectomy in all these cases, or in case of gram-negative or in case of fungus, we go for silicone oil injection, retain the silicone oil till the inflammation and the infection completely reduces. And this patient could get a vision of 6/60. This is Cocuria, I think, and this is one of the rarest organisms which we have never come across commonly. And this was a patient, but this is a post-injection endophthalmitis. So after the diagnosis, core vitrectomy, everything was done, and patient could get a vision of 6/60. These are the other organisms. Coming to gram-negative serratia, this is one of the organisms, not that rare, but not very common also, but very easy to identify. Any patient who comes with a what we call a pink hypopaean, without doing culture, you can say that patient is having serratia marcescens. And this is one of the cases where a 11-year-old boy came with this organisms. Outcome was good. And we had a very unfortunate what we call situation of treating some of the cluster endophthalmitis. This was, we have published only 13 cases in this series, but the numbers were very high. So this was Burkholderia cephacea. It's almost similar to Pseudomonas. Many lab might misdiagnose this as Pseudomonas, but this is a separate entity, very slow growing. And this has happened because of the contamination of the topical anesthetic agent which was used. So the topical anesthetic agent also grew and it was analyzed, and it is the same organism. And in this case, we have gone for piperacillin tazobactam. So nowadays, piperacillin tazobactam 225 microgram is our drug of choice in case of any gram-negative antibiotic. If it is very resistant, we go for colistin. And in most of these cases, you can see here a patch graft was done. And in 13 cases, most of them retained a vision of 6/60 or so. And if you take all the cluster endophthalmitis, fortunately, we had the best outcome among all the Burkholderia cephacea. The second rare negative organisms was Ochrobacter anthropi. This also I came across for the first time. And we had 4 cases from the same institute, again a cluster. So in all these cases, I think 2 of the cases, as soon as we got the culture, we went ahead and we removed the IOL bag capsule component, complex. So when we are removing the IOL bag, every single, the remnant of the capsule should be removed so that there is no multiplication. And most of these cases did very well. And this is not a post-op, but still would like to mention, we had a very rarest organism, that is Vibrio cholerae, coming to us with endophthalmitis. This was diagnosed based on culture. This patient neither had watery stool nor watery discharge in the eye. He came with just a beak injury. But if you see the outcome after the, this was the final outcome, where you can see the whole retina is crumpled over the disc with the bare choroid. The patient was just PL, and the outcome was very bad. These are the other gram-negative which we have come across in our practice. Most of them were fortunately responding. The last we'll be talking about a small cluster. I cannot say it as small cluster. 12 eyes of 10 patients. They all came with Candida pelliculosa. So this is also never reported so far, pelliculosa causing acute post-op endophthalmitis. All of them came within 15-20 days after cataract surgery, but we could not identify the source. But once it was suspected fungus, in all these cases, you can see the vision ranged very good from 660 to 6/9 at presentation. So we had a lot of problem in convincing them to go for IOL explantation. We have done IOL explantation in all these cases. After 4 to 5 months later, we have started implanting. I think 8 out of 12 eyes we have implanted the secondary IOL Gabber's technique, and almost all the cases regained very good vision. So again, in case of any suspected fungal, whether it's Candida pelliculosa or in case of gram-negative, the first line of treatment is go, remove the IOL, bag, CTR, everything, gives a good outcome. And in case if it's gram-negative, it's virulent, silicone oil is our choice. So these are the other species. So just for next 1 or 2 minutes, we'll just see how to diagnose. B-scan is a must because this differentiates TAS also. We can go for AC tap as well as vitreous tap. And the route of administration depends. Intravitreal is the most important. But we have to remember that when you are removing the lens, there are certain antibiotics like vancomycin whose half-life is reduced. And when you are removing the vitreous, there will be reduction in the half-life of beta-lactams and the fluoroquinolones. So we'll have to increase the frequency of intravitreal injection if they are responding. Like in case of voriconazole, the half-life in the vitreous cavity is just 5 to 6 hours. So every 2 days repeating voriconazole in case of fungus is not a bad idea in case if the patient is responding. And I don't have any financial interest. I think every cataract surgeon can have this. This is just 1,500 rupees. It has got all the drugs, vancomycin, voriconazole and dexamethasone. They say it is a single dilution, but I'll prefer a 2-stage dilution. No mathematics involved, just dilute, take 0.1 ml, inject. This can be done by every one of us, including the anterior segment surgeon. So before you refer, have this kit. If you suspect, inject and then refer. Injecting vancomycin and ceftazidime, even in normal eye, is not going to cause any problem because we have got a very high dose of tolerance in case of vancomycin. Up to 6 milligrams can be given without any issues. So as far as vitrectomy is concerned, it's always told core vitrectomy, but we prefer complete vitrectomy where you go for induction of PVD but don't induce beyond the equator. So this is some of the situation where you don't go beyond the equator, but you have to be very careful when you are inducing the PVD. I think it's not working. So when you are inducing the PVD just from the disc, especially nasally, even if there is any collateral damage, there will not be any damage to the macula. And don't go beyond equator. If needed, we can go for silicone oil injection in these cases. There are certain challenges. For want of time, we'll just skip. These are the poor prognostic factors, especially the most important thing is gram-negative organisms on smear usually goes with poor outcome. And if there is no worsening after the injection or if there is no response to antibiotics, then the outcome is bad. So finally, when you're doing vitrectomy, we have to go for the high cut rate with the minimal suction. Silicone oil, especially in case of gram-negative, because of its antimicrobial property, as well as it compartmentalizes the infection, and it also prevents the thing. So basically, after we started using all these intravitreal antibiotics, now we are emerging with new organisms causing endophthalmitis, and we also have a lot of drug resistance. And in case if you are doing core vitrectomy, if you are very confident, we can go for a complete vitrectomy, especially a prompt vitrectomy and a prompt referral is mandatory so that we can achieve good functional outcome. Thank you once again. Thank you, madam.